Hello, everybody. I'm Dr. Monty Pal, your host of the ASCO Daily News Podcast. I'm a medical oncologist, professor, and vice chair of academic affairs at City of Hope in Los Angeles. Today, I'm really excited to share with you my takeaways on selected abstracts from this final day of the 2026 ASCO annual meeting. It's been a terrific meeting so far. You'll see my disclosures available in the transcript. Now, I've picked a couple of abstracts here that really encompass a broad range of topics presented here on day 5. We've got anemia and myelofibrosis. We've got advances in RAS-mutated metastatic colorectal cancer, novel therapies for AML, and also a really exciting and potentially practice-changing trial in triple-negative breast cancer. We're going to kick things off with abstract 6501. This was presented by Dr. Naseema Gangat from the Mayo Clinic, Rochester, and this is known as the RALI-MF study. MF, of course, here refers to myelofibrosis. And one of the things that we know is that hepcidin, which is a central regulator of iron homeostasis, is pathologically elevated in patients with this disease. This really limits iron availability for red blood cell production, and it contributes to anemia onset and the severity of the disease on the whole. The investigators here evaluated DISC-0974. This was an investigational, first-in-class monoclonal antibody that blocked hemojuvelin, which is a co-receptor of bone morphogenetic protein signaling pathways that really drive hepcidin expression. This is an ongoing phase 2 study that they reported out throughout the United States. And in this study, a couple of key eligibility criteria. Patients really had to have primary or secondary myelofibrosis and a hemoglobin of less than 10 or some sort of transfusion requirement. They enrolled into 3 cohorts based on RBC units transfused in the 84 days prior to screening, and patients were characterized as either non-transfusion dependent, low transfusion burden, or potentially a high transfusion burden. And that high transfusion burden referred to 3 to 12 units administered within that 84-day time frame. The primary endpoint in this study was defined by transfusion independence here. With 47 participants enrolled in this study, we had about 30 that were in the non-transfusion dependent category, the remainder in the others. What they ultimately saw was that about 50% of patients in the non-transfusion dependent group achieved a mean hemoglobin increase of over 1.5 points for greater than or equal to 12 weeks. You also see similar improvements to 71% in those patients who really needed to have low transfusion dependence and so on. Major hematologic responses were 50% for participants on and off concomitant JAK inhibitor therapy. You see here that there were also significant improvements in quality of life endpoints as well. They looked at the FACIT fatigue score, a very common estimate used in this population. Really impressive data. DISC-0974 seemed to improve many of the landmarks that they were intending on looking at with anemia response and fatigue. And I do think that this may be a promising approach ultimately in myelofibrosis. Now, moving on from myelofibrosis, I wanted to shift gears here in a big way and talk about metastatic colorectal cancer. We're going to discuss abstract 3510, which is presented by one of my colleagues just down the street from City of Hope, Heinz Joseph Lenz, who's in practice at the University of Southern California, also in Los Angeles. Now, he presented a study known as the CRDF-004 clinical trial. This is a randomized phase 2 experience, and these are interim results, importantly, that look at onvansertib plus standard of care chemotherapy with bevacizumab in frontline RAS-mutated metastatic colorectal cancer. For those not familiar with onvansertib, it's a selective PLK1 inhibitor, and it's previously demonstrated synergy with chemotherapy in the second-line setting. As we know, RAS-mutated cancers are exquisitely challenging to treat. We're seeing some major breakthroughs in managing these patients. But with that in mind, this particular study randomized patients to receive with KRAS or NRAS mutant metastatic colorectal cancer standard of care therapy alone or standard of care therapy plus onvansertib. In this study, I'll mention some of the highlights here. What we saw is that with 110 patients randomized, there seemed to be higher response rates with a combination of onvansertib with regimens like FOLFIRI with bevacizumab. There also seemed to be the same versus FOLFOX with bevacizumab as well. And if we look at progression-free survival, it seemed to be, at least to some extent, improved when you add onvansertib to regimens such as FOLFIRI-Bev. So I would suggest here that this really provides at least some degree of compelling evidence that this agent may have activity in this particular setting. Ultimately, onvansertib plus FOLFIRI with bevacizumab is something that may potentially be looked at in further larger evaluations. I'm going to migrate from metastatic colorectal cancer to the field of acute myelogenous leukemia. This is abstract 6504, and it looks at quizartinib. This is an agent that many of you may be aware of, which is a potent FLT3 inhibitor. This study specifically looks potentially at the ability of quizartinib to improve outcomes with regimens such as decitabine with venetoclax. In this phase 1/2 study, patients with newly diagnosed FLT3 ITD AML who are really unfit for intensive chemotherapy and patients with relapsed and refractory disease who had FLT3 ITD AML were evaluated. There were a total of 88 patients who were enrolled in this study. And what we saw in the context of this trial is that with the addition of quizartinib, we ultimately saw that there was a high complete response rate, deep MRD responses, and encouraging survival amongst patients who were older. To highlight some of the notable elements of the data, what we saw here is that best MRD negativity by MFC and by FLT3 NGS were 68% and 83%. So impressive data in this context. There were about 36% of patients that proceeded to allogeneic stem cell transplant when in CR1. OS wasn't reached versus 36.6 months in those who didn't receive allogeneic stem cell transplant in this setting. So again, a really interesting potential option for patients who have newly diagnosed FLT3 ITD AML. Certainly stands to have further testing performed indeed. What I'm going to wrap up with here is a study in triple negative breast cancer. This is a really exciting abstract, LBA 1003. This was presented by Jiang Wu from Fudan University in Shanghai, China. Again, this really highlights the international nature of ASCO26. A lot of very, very important data sets presented from outside of the country. As we all know, triple negative breast cancer remains a very, very challenging disease to treat. And the authors here evaluated izolantamab. And this is actually a first-in-class bispecific that targets both EGFR and HER3. This randomized study put patients who had unresectable, locally advanced, or metastatic triple negative disease who had previously received 1 to 2 prior lines of systemic therapy, including prior taxane, in a 1-to-1 randomization to receive either Izabren, as we'll refer to it as, or treatment of physician's choice. This could include eribulin, capecitabine, gemcitabine, vinorelbine, some of the standard therapies that are used in this heavily refractory setting. So the randomization was stratified based on HER2 status, based on receipt of prior checkpoint inhibitors, and so forth. And they ultimately randomized a sizable population. 418 patients were ultimately randomized. And what we saw here was that the median PFS when we added Izabren was improved, 8.5 months versus 3.1 months, a hazard ratio there of 0.29. Median overall survival was 15.9 months with Izabren and 12.5 months in those receiving conventional chemotherapy or standard therapies in this setting. Really, really impressive data here. If we look at the most common treatment-related adverse events due to Izabren, these include neutrophil count decreases, white blood cell count decreases, platelet count decreases, so principally hematologic. Ultimately, this pre-planned interim analysis met both dual primary endpoints of progression-free survival and overall survival. Very, very notable data here. It really begs the question of whether or not Izabren may potentially represent a standard of care in this setting. That ends our special coverage of the 2026 ASCO annual meeting. I want to thank you all for listening, and I hope you've enjoyed our top takeaways from ASCO26. Just FYI, you can access the abstracts mentioned today in the transcript, and if you value the insights that you heard on the ASCO Daily News podcast, please remember to rate, review, and subscribe wherever you get your podcasts. Thanks so much.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.